Oop. Good morning, everyone. Boy, we had like 5 people here yesterday, and I think we have 1 today that I heard. Good morning, everyone. Oh, thank you. I feel better when I know that I'm talking to somebody. Well, good morning and welcome to the Medicare Advantage and Prescription Drug Plan Audit and Enforcement Conference and Webcast. My name is Stacy Plizga, and I will be your moderator for today's event. This morning, for our virtual audience, we are gathered at the CMS Central Office Auditorium in Baltimore, where the webcast is originating from. We have a number of CMS subject matter experts and sponsors who will provide important insights on how MA and Part D organizations can best prepare for CMS performance audits. Before we get started, I would like to review some logistic elements that will be helpful for you throughout the day. First of all, materials. Webcast materials are available on the CTEO website that is listed on the screen. If you have not done so already, please go ahead and download those so that you may follow along with the presenters today. Also, continuing education credits. This conference will be evaluated for continuing education credits by CMS, and will give credits for approximately 6 hours of training. The final number of credits will be available after the event. This conference has also been approved by the CCB for continuing education credits, and participants will have an opportunity to earn up to an additional 5.7 credits for this conference. And that information can be found also on the CTEO website, so check it out there. Technical support. If you are having technical difficulties, we do have staff members who are available to assist you. Please use the email box cteo.techsupport@cms.hhs.gov for your technical questions or concerns. For those who are viewing, please remember using an Ethernet connection instead of Wi-Fi and using Google Chrome instead of Internet Explorer may increase your webcast streaming speed and prevent delays. The Medicare Advantage and Prescription Drug Plan Audit and Enforcement Conference will have interactive polling today during the sessions, and also at the end of each session there will be a polling evaluation. That way both our in-house and our webcast participants can interact with the speakers and enjoy the conference. There are a number of ways that you can participate in the polling. One is using a cell phone and using text messaging, and the other is by using a smartphone, a computer, a tablet, and using the web address. If you would like to participate in polling today, and we do encourage everybody to do so, and participate in the session evaluations, which are very helpful, you must first join my session. So I'd like for all of us to do this together, both in-house and our virtual audience. If you can follow along and you would like to join via text messaging, please go ahead and take out your cell phone. Select your text message screen, and in the to box, type in the numbers 22333. And in the message box, you are going to type CMS 2017 Audit. This is not case sensitive, so you can use upper or lowercase. However, please do not put any spaces between the letters or the numbers. Go ahead and send your message, and you should receive a message back that says you have joined the CMS 2017 Audit event. If you got a different message, that means you joined somebody else's event and try again. Great. Also using your smartphone, utilizing text messaging, you can participate in the end of session evaluation survey. In order to do this, the moderator will prompt you with a polling slide that asks if you want to evaluate the session. When that comes up, you will simply type in the letter A. You will receive a message back that says, "Hello, please evaluate this session." And there's a link. All you have to do is click on that link, and it will take you to the evaluation. You will click Start Survey, and it will give you one question at a time to answer. You click on Next, and then when finished, you hit Finish, and your answers will be submitted. If you would rather join Poll Everywhere via computer, tablet, or smartphone using your web browser, again, you must first join my session. To do this, you will open a page and type in www.pollev.com/CMS 2017 Audit. You should see a screen similar to the one that is on this slide. And this just means the poll is not in session yet, just telling you to hang on. When the moderator prompts you and we open a poll, the screen will change. When there is a question, you will simply click on your response and then it will be submitted. In order to participate in the end of session evaluations on your computer or using the web browser, it's very similar. When you are prompted by the moderator, you are going to choose yes in response to the statement, "I would like to evaluate this session." You will be presented with a link. It will appear in the green box at the top of your screen. What is very important here is that it appears briefly, so you have to be quick and you have to click on it. It will then take you to the survey. Go ahead and click Start Survey, and you will be presented with the questions one at a time. Hit Next, and then when you are done, again, hit Finish, and your responses will be submitted. So we're going to go ahead and give this a try together. And the question today is, which emoji best represents your morning? Now, we did this yesterday, and there were a lot of happy people out there. And I'm hoping that we have the same results today. I know it's not quite as sunny today, but there's still a lot to be happy about. All right, great. I want to do this at the end of the day, too, and see how you're all feeling at the end of the day. All right, moving on. Questions. We look forward to everyone's participation today, whether you're in our in-house audience or our virtual audience. For our webcast participants, if you have a presentation-related question at any point, go to the SurveyMonkey link that is on the CTEO webpage. You will simply just click on that link, enter your question, and submit the survey, and we will record it here, and we will get it to the presenter to address. For our in-house participants, we ask that if you have a question that you stand up and go to one of the microphones in the center aisle. And then please, when it is your turn to speak, identify yourself and the organization you are with. Please make sure that you speak into the microphone so that it can be recorded, especially for the closed captioning. It's very important that they can hear you clearly to record what you are saying. If you have a technical question about polling at any time during today's event, please send an email to tclagholtz@provider-resources.com. If you have a technical question about the conference or the webcast today, please send an email to cteo techsupport@cms www.hhs.gov. We are so glad to have all of you here today. We have quite a showing of people and a great number of viewers also on the webcast. I believe we're at about 3,200. So welcome to everybody. Our agenda today is packed with subject matter experts who are very excited to share their knowledge and expertise with you today. So let's go ahead and get started. Kicking things off for us this morning, we have the Director of Medicare Part C and D Oversight and Enforcement Group. Please help me welcome Vicki Hearn.
Thank you, Stacy. Good morning, everyone. I hope the new format of our conferences, having the Part C and D conference yesterday back-to-back with our conference today, makes it a little bit better for everyone, works well, makes traveling easier, and makes it so that you don't have to make two separate trips to Baltimore. Before we get started today, I'd first like to introduce some individuals from our team. Judy Giesler, if you could stand when I call you. Judy Giesler is the Deputy Director for our group. And then we have Jennifer Smith, who is the Director of our Division of Analysis, Policy, and Strategy, and Katie Flannery is her Deputy. We also have Mike DeBella, who is the Division Director for our Division of Audit Operations, and his Deputy is Jessica Robinson. And then we have Kevin Stansberry, who is our Acting Director of our Division of Compliance Enforcement. Trish Axe is our Senior Advisor in the front office. Rick Buskey is our Special Assistant. And Jason Clark Fox, who I'm not sure if he's in the room, is our Staff Assistant. So thank you all for everything you do each day. We have a lot of interesting and informative sessions for you today, and in an effort to continue to improve our processes, we'll be sharing significant enhancements that we've made to the audit process, provide more detail about specific elements of our data universes, review our revised approach to our compliance program effectiveness protocol, talk about our civil money penalties, and give you a snapshot of our annual report, which we just released this week. I'd also like to make you aware that we will soon be releasing more detailed information on our independent validation and audit closeout process. And at the same time, later this summer, we will actually be doing a listening session on this topic, and we encourage everyone to participate in that. We welcome any feedback or thoughts that you have on how we might make that process easier. I would also like to encourage you to utilize the various tools that we have available to help you monitor and improve your processes with our requirements, and ask that you continue to provide specific examples to us of how we can enhance these tools. And before I turn it over for our first presentation, I'd like to thank our whole MOAG leadership and all team members who do their work every day and are really dedicated, and also thanking those who are speaking today for sharing their expertise. Also like to thank Matt Stoll for being our point of contact for this conference, our business operations staff for putting together today's conference as well as yesterday's conference, and for the sponsors that we have speaking as well. So thank you again for your time today, and as always, if you have any comments or concerns, or just want to provide information or feedback on things that are going well, please contact me, and enjoy the conference. Thank you.
Okay, our first session today, let me get this up here, consists of a panel of speakers who will discuss enhancements and changes to the program audit process in 2017, as well as provide helpful tips about submitting audit universes and understanding record layouts. From the Division of Audit Operations, it is my pleasure to introduce Fatima Mohammed, Angelique Morris, Doreen Galliano, and Marie Gutierrez.
morning, everyone. My name is Fatima Mohammed, and alongside me is Angelique Morris. We'll be discussing the 2017 audit process. We'll first walk through, at a high level, the phases of an audit timeline, and then highlight significant changes and improvements CMS has made to the process as a result of feedback we've received from the industry. Every year, we evaluate the feedback we get through our audit survey, the mailbox, and other forums. We do our best to make changes that both improve the audit process and reduce the burden on sponsors that we audit. In addition, my colleagues Doreen Gagliano and Marie Gutierrez will be discussing helpful information regarding universe submissions and record layouts. The 2017 audit process timeline. Program audits are conducted in 4 phases: the audit engagement and universe submission phase, the audit fieldwork phase, the audit reporting phase, and the audit validation and closeout phase. Each phase consists of key milestones, which will be outlined in the following slides. So as you can see, the entire audit process, from start to finish, extends about 1 year. Phase 1 is known as the audit engagement and universe submission phase. We've highlighted 3 important milestones that occur during this phase: the engagement letter issuance, the universe submission, and universe integrity testing. The issuance of the engagement letter marks the beginning of the audit. Within 15 business days of the engagement letter date, sponsors must submit all requested universes to CMS following the instructions outlined in the engagement letter, instructions and attachments. Within 1 week of the receipt of universes, CMS conducts universe integrity testing to verify the accuracy of submitted universes. To conduct this test, CMS selects samples of cases in the universe and matches the information to the sponsor's live systems. CMS conducts these tests virtually via webinar. So some enhancements or changes to the audit process in universe phases were the engagement letter modifications, the creation of the audit submission checklist with the issuance of the engagement letter, changes to the reporting for the pre-audit issue summary, which includes sponsor disclosures, and a note that all universes will be submitted in HPMS and not SFTP. So we'll be discussing these enhancements in more detail in the following slides. So in highlighting phase 1 significant changes, the engagement letter content has been improved. CMS improved the engagement letter process by transmitting all critical information through the engagement letter. There is no longer an engagement letter follow-up email. We have also created several materials that reside in HPMS that will assist sponsors in understanding the audit process. These materials include the 2017 Program Audit Process Overview, and this is also posted publicly on our CMS Oversight and Enforcement website. The on-site information and request document has also been included, and then lastly, the audit submission checklist. The audit submission checklist. So new, as I said, new in 2017, it is meant to provide the compliance officer and organization an organized list of all audit deliverables due to CMS by audit fieldwork. It is attached directly to the engagement letter. It also identifies universe periods and due dates. It identifies the method and location of submission, and then it allows compliance officers to easily track submissions. So as an example, we'll briefly walk through a snapshot of the audit submission checklist. The checklist displays the audit-specific engagement letter and entrance conference dates at the top. So please note that this checklist has been modified to show you examples of deliverables in each program area. So starting from left to right, the level association in HPMS and upload file type columns both identify the location that the specific request should be uploaded to. All documents should be uploaded to HPMS again. We will no longer be using SFTP when uploading universe files. I should also note that CSV files will not be accepted at this time. The audit request type columns give sponsors insight into the type of request, such as universe files, questionnaires, or other documentation. The audit submission name column is the actual naming convention CMS would like for sponsors to use when uploading requests. One thing to note for universe request types, HPMS will automatically rename the file upon upload. So the naming convention is only important for supplemental file types. The universe period column identifies the time periods of data that CMS needs for the respective universe. These dates will vary from audit to audit. And lastly, CMS has identified the due dates for each request in the far right column. Another significant change made within Phase 1 was to the pre-audit issue summary. Only sponsors' disclosed issues are reported in the pre-audit issue summary. CMS is no longer requiring the disclosure of self-identified issues that have not been previously reported to CMS. A disclosed issue is one that has been reported to CMS prior to the receipt of the audit engagement letter. Issues identified by CMS through ongoing monitoring, account management, or oversight activities during the plan year are not considered disclosed. Sponsors must provide a description of each disclosed issue, as well as the status of correction and remediation using the pre-audit issue summary. This template is due within 5 business days after the receipt of the engagement letter. And so when CMS determines that a disclosed issue was promptly identified, corrected, or is actively undergoing correction, and the risk to the beneficiaries has been mitigated, CMS will not apply the ICAR condition classification to that condition. So now I'll turn it over to Angelique Morris to discuss phases 2 through 4.
Thank you, Fatima. So as Fatima stated, I'm going to discuss phases 2 through 4 of the audit process. Phase 2 encompasses weeks 7, 8, and sometimes 9, and is referred to as the audit fieldwork phase. Fieldwork begins with an entrance conference conducted virtually via WebEx. The auditor in charge will lead the conference, review the schedule, and discuss expectations for the weeks ahead with the sponsoring organization. The sponsor will also have an opportunity to make a presentation about its organization during the call. After the entrance conference, the virtual webinar will begin. CMS customarily conducts the audits of each operational area virtually via webinar, with the exception of the Compliance Program Effectiveness, and this is the CPE program. The review is conducted at the sponsor's location during the last week of fieldwork. Several enhancements have been made to the CPE protocol and will be discussed in depth during the next presentation. At the conclusion of the audit fieldwork phase, which is after the on-site CPE review, CMS will issue a preliminary draft report 1 hour prior to the exit conference, where the audit team, broken down by operational areas, will discuss the preliminary results of the audit. During the exit conference and discussion of the preliminary draft report, CMS will not be reporting any condition classification. The meeting will consist primarily of the overall preliminary findings and outstanding documentation. CMS prohibits the recording or taping of any audit activities. So some significant changes to Phase 2. CMS has extended the time frame from 1 business day to 2 business days for submission of supporting documentation for non-compliant or pending case samples. Documentation may be in the form of screenshots, member letters, case notes. When attempting to determine the cause for noncompliance found during an audit, CMS will request a root cause statement from the sponsor. We have extended the time frame from 1 business day to 2 business days for the submission of this information. An impact analysis must be submitted as requested by CMS. The impact analysis must identify all beneficiaries subjected to or impacted by the issue of noncompliance and all applicable contracts. CMS has extended the time frame from 5 to 10 business days to complete the requested impact analysis. The 10 business day period will not begin until the conclusion of the first week of fieldwork, which is marked by the status call. Fieldwork will be extended to 3 weeks when a Medicare Medicaid plan or MMP plan are included in the scope of the audit. Because MMPs will have separate protocols in 2017, additional webinar-based reviews must occur and extend the fieldwork phase from 2 to 3 weeks. Week 3 will conclude with an on-site audit of the compliance program. The MMP audit protocols will be discussed more in depth during a presentation today. And as I previously stated, the preliminary draft audit report will be reduced in HPMS and will be available 1 hour prior to the exit conference. So now we're going to talk about Phase 3, which is known as the audit reporting phase and occurs between weeks 9 and 21. So during this phase, we have the notification of the immediate corrective action, which is the ICARs. CMS notifies the sponsor of any conditions requiring immediate corrective action after the issuance of the preliminary draft report, but prior to the issuance of the draft report. The sponsor is responsible for submitting corrective action plans or CAPs for each ICAR condition identified. The ICAR notification will be sent via email from the auditor in charge. In addition to the ICAR email, the sponsor will receive notification from HPMS regarding the draft report. So the draft report is inclusive of condition classification and audit scores to the sponsor approximately 60 days after the exit conference. The sponsor will have the ability to respond to the draft report and submit comments 10 business days after the receipt of the draft report. So you have up to 10 business days. And then the final issuance of the final report issuance, CMS will respond to the sponsor's comments and update the audit score if applicable. And we have a target issuance date of 10 business days after receipt of the sponsor's comments to the draft report. So some significant changes to Phase 3. Submission of corrective action plans or CAPs for individual conditions is completed directly in HPMS now. While the Program Audit Consistency PAC teams are not new in 2017, the PACs have continued to evolve and have become more sophisticated by developing tools that assist with decision-making, tracking condition classification, and dealing with complex subject matters and audit policy issues. PACs are comprised of CMS subject matter experts within each program area and ensure consistency and classification in all audits. So for Phase 4, which is known as the audit validation and closeout process, this occurs between weeks 22 and 48. Upon CMS acceptance of all CAPs, the auditor in charge will send a formal email which will confirm the acceptance of the caps and kick off the validation process. The validation review may be conducted by CMS, or a sponsor may be required to hire an independent auditor to validate the corrections. CMS will advise sponsors at the time of issuance of the final audit report if an independent auditor is required to validate corrective of the conditions noted, or if CMS will conduct the validation internally. The sponsoring organization has 150 calendar days from the date of the CMS acceptance of the sponsoring organization's caps to undergo a validation to demonstrate correction of all audit deficiencies as outlined in Appendix A of the final audit report. To begin the sponsor validation audit process, CMS holds a kickoff call with the sponsor 1 to 2 days after the caps are accepted. When the validation audit work plan has been completed, it must be sent to CMS to review and approve prior to conducting the audit work. Lastly, the results of the validation audit are sent to CMS for review to determine if sufficient correction of audit conditions have occurred and if the audit can be closed. Later this year, CMS will plan to conduct the industry listening session to give feedback on how the independent auditor process has been working and what improvements CMS can make to the process to make it more efficient for all parties involved. I'm now going to turn over the presentation to my colleagues Marie Gutierrez and Doreen Gagliano, who will discuss helpful information regarding universe submission and record layout.
Great. Thanks, Angie.
You're welcome.
Good morning, everyone. My name is Marie, and Doreen and I will be providing clarifying guidance regarding record layouts to ensure proper universe submissions. We'll be focusing on commonly asked questions we've received from the Part C and D mailbox and those encountered during audits about certain record layouts. Specifically, it pertains to the following program areas: Part C and D, Part C organization determination, appeals and grievances, so that's ODAG. Part D coverage determination, appeals and grievances, which is CDAG. Formulary administration, FA. Medication therapy management, MTM. And special needs plans, model of care. So let's start with the ODAG program area. There are 14 record layouts, and the 14th record layout is new, and that's the call logs, and that's new in 2017. Actually, some of you may have seen that in prior audit years, as we use that as a supplement to grievance universes, but in 2017, it is a required record layout. And we'll start by discussing clarifying guidance that applies to record layouts 1 through 13. So we'll talk about call logs lastly. So for ODAG record layouts 1 through 13, the instructions state to include all requests processed as, and process means the way the sponsor handled the request. So for example, if a request came in as an expedited pre-service organization determination request, but the sponsor processed it as a standard case, then it must be included in the standard pre-service organization determination universe and not the expedited pre-service organization determination universe. So really, put it in the record layout the way you, the sponsor, process the case and not necessarily the way the request came in. So some of the record layouts explicitly state to exclude withdrawn cases, but this applies to ODAG record layouts 1 through 13. So please do not include withdrawn cases in any of these record layouts. In regard to the date written notification provided field, we still get some questions about this, and provided means when the notification left the sponsor organization or its delegated entity. So for example, it's the date the letter was mailed. It is not the date the letter was generated. If a mail vendor is used, it is the date of the notification, the date the notification left the mail vendor. If the sponsor sends it via U.S. mail, it's the date the notification left the sponsor organization. So along the same lines, in regard to the date paid field, paid or issued payment means when the payment left the organization. And this applies to our payment organization determination, DMR, and payment reconsideration universes. So if a payment vendor is used for an electronic payment, it is the date the electronic payment left the organization, as the organization already set that payment in motion. If the sponsor sends a check via a mail vendor, it's the date the check left the mail vendor. If the sponsor sends a check via U.S. mail, it's the date the check left the organization. Let's talk about AOR receipt date. That applies to our pre-service organization, pre-service reconsiderations, and grievance record layouts. So if the AOR is required but not yet received at the time of the universe submission, the case must be excluded from the universe because it's not yet a valid request. So for our pre-service record layouts, that's 1, 2, 5, and 6, oral notification is valid by speaking with the enrollee or authorized representative directly, leaving a voicemail with instructions to contact the plan for additional information about the decision, or by making a good faith attempt to contact the enrollee or the authorized rep. So let's define good faith attempt. And that would be calling the enrollee's preferred number without actually speaking with them, and the good faith attempt must be properly documented in the sponsor system to qualify as a good faith attempt. This policy applies to both oral approval notifications and oral denial notifications, followed by a written denial notice. So our tables 1 and 2, the SOD and EOD universes, record layouts, explicitly state to include all supplemental services such as dental and vision, but this language is omitted from record layouts 3 and 4, which is our claims and DMR record layouts. So supplemental services must be included in record layouts 3 and 4, as well as record layouts 1 and 2. So here's our new record layout, table 14 call logs, and the protocol states to use the name of the first tier downstream and related entity that processed the dismissal. So please use the name of the FDR that processed the call and not the dismissal. So at this time, I'd like to pass it on to Doreen, who will talk about CDAG, FA, and MTM.
Okay, thank you, Marie. For the CDAG program area, we actually have 16 different record layouts, and the 16th this year in 2017 is our new call log record layout, which is unique to all the other ones. And we will start by discussing some clarifying guidance around record layouts 1 through 15. For record layouts 1 through 15, all the CDAG universes, you will want to enter and ensure that you submit the cases based on the date that they were processed or should have been processed. We get this question a lot in our audit mailbox, so we wanted to provide clarity around that. So that means that you would submit all cases based on the way that you handled it. For example, if a case came in and was a request for an expedited coverage determination, but you processed it as a standard coverage determination, then you would enter it and list it in the standard coverage determination record layout, not the expedited. For record layouts 1 through 8, we have instructions that state you should submit the case based on the decision that was rendered or should have been rendered. Sponsors should submit all cases that were decided or should have been decided during that particular universe period that has been identified in your engagement notice. Therefore, these may be cases that were received prior to the universe review period those would also be included because it's based on when your decision was rendered. For CDAG record layouts 1, 2, 4, 5, 8, 14, and 15, we're going to talk about oral notice. Again, another question that we get a lot. So the date the oral notification was provided to the enrollee would be when you have a valid outreach attempt, so speaking with the enrollee or their authorized representative directly, or as Marie said in ODAG, making a good faith attempt. A good faith attempt would be calling the enrollee at their preferred phone number without actually speaking with them, and the good faith attempt must be properly documented in the sponsor systems. For CDAG record layouts 1 through 10 and 14, in the field that is titled Date Written Notification Provided to Enrollee, this term, again, means when the letter left the sponsoring organization or delegated entity's establishment by U.S. mail, fax, or electronic communication. So just as Marie said in ODAG, please do not enter the date that the letter was generated internally, but let's say you send it to a vendor and it was not mailed out for 2 or 3 days after that. That would be the date that we would want to see in the record layout, the date that it actually left the establishment. CDAG record layouts tables 6 through 8, under the field name or the description of was the request denied for lack of medical necessity, we would like you to please insert whether the initial coverage determination request was denied for lack of medical necessity. And for record layouts 6 through 8 again, the field name, if it was denied for lack of medical necessity, was the review completed by a physician? We would like you to indicate whether the redetermination review was completed by a physician. So this is just providing clarifying guidance to make sure that you're entering information correctly in that record layout for those. And for CDAG record layout table 16, so our new call log, we would like you to include all Part D calls that were received by your organization or your delegated entity from an enrollee or their representative, and if it was received or transferred to your member customer service line. Do not include prescriber calls in Part D call logs, and do not include non-Medicare lines of business or sales calls. Next, we're going to move to formulary administration record layouts. There are 5 different record layouts that we want to provide some clarifying guidance on. For FA tables 1 through 3 and 5, so this is all the record layouts except for PDE, the field name enrollment effective date and effective disenrollment date. Both the effective disenrollment and enrollment date should be reported at the plan benefit package level. The enrollment and disenrollment dates submitted in the rejected claims universes should be relevant to the contract and the plan ID of the beneficiary at the time of each claim. In the new member universe, a separate record should be entered each time a beneficiary is enrolled and considered a new member. The enrollment and disenrollment dates for each of these records should also be relevant to the associated contract and plan IDs submitted by the sponsor for that beneficiary. For FA tables 1 through 3, the reject reason code and pharmacy messaging, if both reject codes and pharmacy messaging exist for a rejected claim, but the exact association between them cannot be identified, the organization is permitted to enter the individual reject code in the reject reason code field, followed by all the messaging for that claim in the pharmacy messaging field. This should be repeated for all reject codes appearing for that rejected claim. When pharmacy messages for a rejected claim exist without a reject code, the organization should enter NA in the reject reason code field, followed by the messaging for that claim and the pharmacy message field. For FA tables 1 through 3, the patient residence and pharmacy service type, values should reflect what was submitted by the pharmacy on the claim for these particular fields. While this may typically be an NC PDP value, other values included on the claim would also be accepted. For FA tables 1 through 4, the NDC field description should be populated in the format that was provided in the NC PDP data dictionary. The rejected claims universe should include the NDCs that were submitted on that claim, regardless of whether the NDC was determined to be invalid after processing. NDC should include the 11-digit value as submitted by the pharmacy and, when applicable, should remove special characters separating the labeler, product, and trade package size. And in the event a multi-ingredient compound does not include at least one Part D covered drug, populate the NDC field with 11 zeros to remain consistent with the 11-digit NDC drug code. FA tables 1 through 3 and 5. When you're determining new versus continuing enrollee status for the purpose of the universe submission, there may be a difference among sponsors in determining new enrollment status for beneficiaries that change plans and contracts under the same organization from year to year during a contract year. So organizations should identify such members as new versus continuing for purposes of universe submission, based on their internal policies and procedures. After receipt of a program audit engagement letter, organizations will have the opportunity to discuss their approach to help ensure complete and accurate universe submissions. Moving on to MTM record layouts, we have 2 different record layouts in the MTM area. For MTM record layout table 1, MTM eligibility date versus MTM enrollment date. The reason for the 2 separate fields for MTM eligibility and enrollment dates is because although systems could be developed to auto-enroll beneficiaries into MTM immediately after they have been flagged as eligible, this does not always occur in practice. MTM record layout table 1 continued. The field name was the enrollee residing in a long-term care facility. Sponsors should use the patient residence code on the submitted drug claims to determine that information. And for the number of comprehensive medication reviews, CMRs offered, as noted in the field description of the number of CMRs offered, in order to count as a CMR offer, it must have been received by the MTM program member. Returned mail or incorrect phone numbers do not count as an offer. For audit purposes, if a CMR offer is successfully delivered, it may be counted regardless of whether a response was received or an action was initiated by the beneficiary or the AOR. For the number of CMRs administered versus number of written CMR summaries, a CMR summary may either be provided immediately following a CMR or distributed separately within 14 days of the CMR. Therefore, the CMR administration and written summary dates may be different. For the enrollment effective date, if there is only one enrollment date within the audit period, or the enrollment date is outside, which would be before the audit period, enter the last effective enrollment date in the field. If multiple enrollment dates exist within the audit period, enter the first enrollment date that occurred within that audit period. All right, let me go ahead to the next one here. All right, and for the number of TMRs performed, targeted medication reviews or TMRs conducted by the sponsor no less than quarterly for all beneficiaries enrolled in the MTM program, and these assessments could be person to person or they could be system generated. And now I'll turn it back over to Marie.
Great, thanks, Doreen. So now let's talk about SNPMOC, which has 2 record layouts and 8 documentation requests. I will discuss clarifying guidance that applies to a record layout and some of the documentation requests. So for SNP mock record layout table 1, enrollees that switched from one plan to another during the review period should be included in the SNP-E, so that's table 1 record layout, as separate entries. In such instances, the numbers will appear in the SNP-E universe for each contract or plan in which they were enrolled over the duration of the 13 continuous months. In regard to the HRA during the current audit period, enter no if the HRA was not filled out and returned by the member. Sponsors will have the opportunity to provide information on their outreach efforts during case review to satisfy compliance. For the cumulative dollar amount of Part C and D claims paid field, enter the amount the sponsor paid. Do not include the member's cost-sharing amount. So it's basically the cumulative dollar amount paid by the sponsor. Next, we'll look at some documentation request clarifications. This one is specific to models of care. Please submit your original approved models of care and any redlined updates to the originally submitted mocks. This will help auditors understand the improvements and changes that you have made to models of care. About the HRA submission related to the HRA tool, submit the one CMS reviewed and approved during your MA application or SNP proposal review process. Do not submit additional tools that may be used internally by the sponsor. Policies and procedures related to enrollment and eligibility verification. Please include information related to state agency eligibility verification and enrollment. Include the care coordination policies and procedures that contain outreach provisions for HRA administration or individual care plan development, if not addressed in your mock. And performance monitoring reports include quality improvement committee reports, corrective action plan progress reports, and any reports presented to stakeholders, senior leadership, and the board. Now, this next slide is our general universe clarifications. So the first bullet talks about when the sponsor does not have any cases that meet the record layout request. In that scenario, the sponsor should upload the universe template with a sentence attesting that they do not have such data as requested. The second bullet is about coverage requests that is received prior to the enrollee being effective in a plan. So in that scenario, use the plan ID that was in place at the time of the enrollment effective date. The third bullet is about fields for a single case being in the same time zone. So for example, if a sponsor has a system in Eastern Time and then also in Central Time, all data in a case for that single line item within that universe are to be converted to a single time zone. Let me talk through that one more time. So we'll say you have a line 10 that should reflect, we'll say, Central Time in that system, and then you can have a case in line 20 that would reflect Eastern Time, again, across that single line item case. And lastly, if using abbreviations that are not universally recognized, please include a description. So this box, we offer to you our Part C and D audit mailbox email address. If you have any questions or about the protocol or our audit process, please submit your questions to the email box up on the slide. And we also listed our Part C and D audit website where you'll find the protocol and other wonderful, great audit documentation information. So that concludes our presentation, and on behalf of Fatima, Angie, and Doreen, thank you for your attention.
Okay, if we do have questions from our in-house guests, please step to the center aisle to a microphone, introduce yourself, and tell us where you're from. Oh. Could we turn on the microphones in the aisle, please? Hey, you want to check on the mic? I forgot to bring the prefab. I left it in there. You got it. Is it on now? Yeah, there might be a switch on that map.
Thank you. Okay, good morning. I'm Michelle Johansson from Performer X. Thank you for this very in-depth presentation on the changes themselves to the universes, and it's something that we have a particular passion for. I have two questions, one related to the CDAG universes on slide number 29. So what I understand the clarification to mean is that on the redetermination universes, we're expected to give the information related to whether the original coverage determination was denied for medical necessity. So one is a comment and one is a question. So the question is, what's the justification for that? And the reason I'm asking is our comment. From an automation perspective, we're able to pull the system information that says this is what happened for that redetermination. The prior decision is not attached to that case. And so as a PBM, you know, when we recently went through the appeals monitoring program, every last one of our plans was selected for the audit. And that means that we're producing universes for multiple plans at the same time. Mm-hmm. That's thousands of cases. This is a field where if we follow this instruction, we would have to manually research the previous case until we can build programming to align them. And that's a similar feedback for slide 40. And that's the MTM. Just a moment. Let me get it together here. 40. So the record layout request and the clarification utilize the patient residence code on the submitted drug claims. Again, our MTM system is based on the beneficiary, and they're presumably using a high number of drugs. So are we supposed to base it on one LTC claim or more than 50% of LTC claims? Again, having to go into the claim system to look at the drug claims creates a physical and operational challenge that would make it a manual effort for thousands of beneficiaries.
Yeah. Okay, so I definitely understand the burden being a PBM and having to pull that high number of data for multiple different sponsors. So to address the CDAG question first, on slide 29, the reason that we ask you to identify whether that initial coverage determination request was denied for lack of medical necessity is because we need to play through the case. So if you, on page 30, we're asking about the redetermination review. So obviously, if the original CD was denied for lack of medical necessity, then it helps us identify what needs to happen in the redetermination phase. So one being that it would have to be reviewed by a physician, and a physician who has knowledge in that particular area of medicine that the request is coming in for, or the drug. And so that's why we need to know the difference between those two. Now, if it is burdensome and it's such a manual process, I think that we could probably talk with the auditor in charge and determine what we could list in there instead. We could potentially list NA, and then we would have to determine when we go through each of the sample cases if that was in fact denied for lack of medical necessity. Okay, that's awesome. So we can work with you is what I'm trying to say. Like, yeah, don't stress out about that. Okay. Just let your auditor in charge know what the issue is, and then we will definitely find a solution.
Super accommodating. Yeah. Thank you.
Yeah.
All right. Thanks very much.
You're welcome.
Good morning. My name is Tammy Jarowski. I'm with TMG Health. And my question is actually on ODAG claims, which was slide number 19 as part of the presentation. And the question has to do with the date paid and the date written notification provided to the provider when you have an electronic transaction. So I'm referring to EFT and ERA. And I believe you specifically stated that if you have an EFT or ERA vendor, that you should use the date that the transaction is given to your EFT and ERA vendor. And I just wanted to confirm that, because when you give a transaction to an EFT and ERA vendor, yes, it's leaving your organization, but it could be a day or two before that EFT and ERA vendor actually effectuates that payment or that ERA. So I just wanted to confirm the date that should be used. As again, similar to the PBM, TMG is a BPO, so we're creating these universes across multiple clients and contracts. We want to make sure we're doing it correctly and consistently.
Thanks, Tammy. So the simple answer is yes, I am confirming that that is the date. So for EFT transactions, it is the date that the sponsor put the payment in motion and sent it to its vendor, to its paying vendor. That said, if the sponsor is using, so for the electronic payment,
Correct.
if it's a check, it is the date the check left the organization and was mailed out. If they're mailing it via a vendor, it is the date the vendor mailed it out. If the sponsor is using US mail, it is the date that it left the sponsor because it went to the US vendor. But yes, good catch. There is a variance there, and the thinking behind that is we recognize that the sponsor put the electronic payment in motion, albeit it's to its vendor. So we do, as a policy, accept that the date the electronic payment went out and left the sponsor as the payment date.
Great.
Does
Thank
that
you very
help?
much.
You're welcome.
Good morning, Derek Fry from the Birchfield Group. I actually have a question on the independent validation audit process. So when you guys do a regular program audit, you give sponsors the samples for the webinars 1 hour before the webinars start for that day for most of the sessions other than SNP, et cetera. Is the independent validation auditor, can we follow the same process? Can we give them samples the day before? There's not a lot of clarity around that, and just wanted to get the question out.
Thanks for that question, Derek. Yeah. So first, I just want to mention that when you are undergoing validation, your auditor in charge will be the primary point person. So I just want you to know that you will have support during that time frame. So should you have questions like this, please do direct those to them. But in regards to the IA process, most sponsors we find do follow the protocol outline when they're doing their validation. So it doesn't really matter to us how soon you get the samples. It's okay if you get them a little sooner or, right on the spot. But like I said, most sponsors do go ahead and most IAs use the same protocol and the same timing that we do for the actual live audit. But it's not prescriptive. Okay. Is what I'm trying to say, which is why there's not a lot of guidance around how the IA should deliver samples or the timing.
Perfect, thanks.
Yeah.
Good morning, Mike Sneckenberger from Anthem. Staying on the slide 19 from earlier, and greatly appreciate the clarifications today. Taking that initial clarification, but stepping through to some later tables, Table 9 and Table 10, which is the IRE payment and the ALJ MAC requirement effectuation. More specifically, looking at the fields for completion where we have to enter whenever items were effectuated within the sponsored system. If that results in payments, is that looking for the date that the payment is made to? In other words, does that same clarification hold true here too, or is it when it's effectuated inside the actual system?
Max, real quickly, and to clarify, we want to make sure we're addressing it for the appropriate program area. Were you referring to ODAG or CDAG?
ODAG.
So for ODAG, so an effectuation of the payment specific to your question, it would be the payment date.
Okay. Okay. One other quick question here regarding Table 3 in the claims universe. The instructions request to submit payment organizations based on the date the claim was paid, should have been paid, notification date of the denial, or the date the denial notification should have been sent. Around that notification date, we notify the enrollee and also the provider. So when we're pulling together the universe, if those dates are different for the notifications, which one should we leverage?
Please use the notification date to the beneficiary.
Okay, thank you.
Thank you.
Hey, good morning. Britton Whitbeck from Lumeris. And again, I want to agree with the commenters. We appreciate all the clarity that was in this presentation. I had a question for the ODAG universes where the field for diagnosis codes, it states that if there's a drug that it should include both the NDC and the diagnosis code. And just kind of wanted to get clarity on the value of inclusion on that, and then kind of a comment kind of similar to the CDAG appeals cases. It involves a lot of manual intervention to identify those Part B drugs, and then often the determination is made by the plan sponsor, but the adjudication is happening in the PBM system. So we have to research those drugs to include the NDC in the ODAG universes.
So to clarify, are you saying the NDC information is not readily available in the system?
Correct. In the plan sponsor system, we capture it in our PBM claim adjudication,
Sure.
but the diagnosis code, the ICD-10, is readily available.
Okay. So again, big picture, the intent of grabbing, asking for that information is so we can determine and get a handle on what kind of claim that is, right?
Okay.
So yes, ideally it would be an NCD code. If that's not readily available, you can do an ICD-9 code or a description. So again, as long as it's meeting, well, I'm sharing with you the intent and the purpose as to what we use that column for. And of course, we, as Doreen mentioned, we want to work with you and not add more, work for you to do that manual lookup and stuff.
Excellent.
Great.
Thank you very much.
You're welcome.
Oh, I'm sorry. I actually had one more.
No, that's it. I'm just kidding.
There's a limit. On the dismissals universe,
Sure.
I appreciate the additional clarification in 2017 on the type of dismissals that should appear there
Okay.
and the compliance requirements. Do you know if if we anticipate an update to either Chapter 13 of the Medicare Managed Care Manual or an HPMS memo that kind of outlines plan sponsor responsibilities for the different types of dismissals?
So off the cuff, yes, Chapter 13 update would be wonderful, and we hope our sister group will, I know our sister group, MEAG, is diligently working on getting an update to Chapter 13.
Excellent. Thank you again for the presentation.
You're very welcome. You sure you don't have another question?
Good morning. John Tanner, Molina Healthcare. For entry of IAs and CAPs and that kind of information directly into HPMS, will we be allowed to do file uploads, or is all that going to have to be entered directly into it, like in separate fields?
For impact analyses? During the audit, during the live audit?
Yes.
Okay. Yes, you would be able to upload those right into HPMS, and there actually is a folder that identifies impact analysis.
Okay, good. So
Yeah.
it'll be a file. We won't have to do separate direct entry.
Exactly.
Okay, good. Thank you.
Yep. Hi, I'm Vanessa Turner from Emblem Health. I had a quick question about the special needs plan model of care template. So I really appreciate the clarification that you should only enter in yes for whether a plan conducted an HRA if the response is received. But I think Chapter 5 advises that plans can use several different mechanisms to administer the HRAs, including mail. And so they also seem to indicate that plans must have processes in place to address members who are resistant in responding. And so I know that a lot of plans build out outreach procedures. And I noted in the past couple of years, Part C and D reporting now at direct plans or require plans to report outreach attempts for members who are who refuse to respond to an HRA and members who it's difficult to reach. I wonder if for future derivations of these templates, whether outreach attempts would be included in these templates as well.
Great question, Vanessa, and you got me. But I promise to look that up. I want to make sure I give you, the right information and the current information. So I will get back to you at our Q&A session at this afternoon.
Okay, thank
Great.
you.
Okay, we have time for one last question, and if there are more than that, please hang on to them. We will have an open Q&A session at the end of the day where you will have an opportunity to ask more questions.
Hello, Tammy Jarowski from TMG Health again. One more question, and really it's a clarification on a gentleman's question just asked a few moments ago. Again, on Table 3 ODAG claims and how the universe should be pulled. The universe states that it needs to be pulled based on the date the claim was paid or should have been paid or notification sent. And I believe his question was notification to whom? And your answer was to the member. And that confuses me a little bit because what if a plan is sending a monthly EOB? So it's really typically not based on the notification to the member. It's usually based on the notification to the provider. And I just wanted to make sure I understood that.
So the monthly EOB is what goes out to the provider.
To the member. So the plan has the ability to do a per claim EOB or a monthly EOB. So typically when, in past guidance, or at least the way we understood it, the claims that need to be chosen for your universe, for the scope, is all based on payment to the provider and not based on the EOB to the member. And I just want to make sure I understood your previous comment because that kind of changes everything.
Okay. You're right. The EOB would go to the member. If it's monthly, if it's in that monthly EOB, then I would deduce that those are approvals.
They could be
denials with the appeal languages in there. Okay. Then yeah, it would be that. But Tammy, I want to make sure that I am not changing everything and affecting everything on your end as well. So as with Vanessa, I promise to answer that question at the Q&A later on this afternoon. So I'll owe you an answer.
Thank you.
Thank you.
Okay, thank you for all the great questions. And like I said, we will have an opportunity later today to continue the question and answer period. So at this time, I would like to thank our panel for the discussion on the audit process. Can we move to the polling slide, please? So it is time for our first session evaluation. So please take out your cell phones or your tablets or however you are connected via polling. And you're going to respond to the question, I would like to evaluate session 1. And if that is the case, as soon as it comes up, you can go ahead and select A. There we go. Once you select A, you are going to get a link. Click on that link, and then you will click Start Survey, and then respond to the questions. Please remember to hit Finish when you are done. We are delighted to have with us today speakers who will provide us with an understanding of the new design and objectives of the 2017 Compliance Program Effectiveness Audit Protocol. They will also explain the purpose, structure, and content of the 2017 MMP Audits protocols. Please help me welcome Vernisha Robinson-Savoy, Lauren Brando, and Marla Rothaus.
Awesome. Hello, everyone. My name is Vernisha Robinson-Savoy, and today I would like to engage you for approximately 20 or 25 minutes before I hand it over to my colleagues to provide some insight on the newly redesign of the Compliance Program Effectiveness Audit Protocol. So just a quick little funny, myself, Marla, and Lauren were joking backstage, since all the questions for the conference were discussed in the previous discussion and presentation, we don't expect any. So we're hoping that that's the case. If not, please ask your questions. So let's get started. Okay, very short agenda for today. My main goal here is to provide some detail on why we have taken a new approach for 2017 as it pertains to how we evaluate the compliance programs of Medicare Advantage organizations and prescription drug plans. And many of you, I've had the pleasure of working with either through audits, through answering questions through our audit mailbox, through questions that we receive during the PRA process of clearing the new protocol, and just feedback over the 7 years that we've been auditing compliance programs using our outcomes evaluation approach. And so I was tasked with redesigning a tool to take our evaluation to the next step. So we are confident through our audit cycles that majority of our organizations that contract with us for Medicare have the structure and the processes that make up their program that detects, corrects, and prevents noncompliance and fraud, waste, and abuse. So now that we have some confidence that you have the structure in place, we're now taking it to the next level to evaluate, okay, so what happens when those situations occur in your organization? So that's what I'm going to be focusing on is the significant changes. And then briefly, there's actually a number of slides that I may not go into in detail, but it's also for your reference of the record layout clarifications, some technical guidance that we've are aware of that will help you with your universes. Okay, so just a little feedback, not feedback, just an overview. Over the last 6 months, as many of you may have participated, our audit protocols for 2017 were issued for public comment. So specifically for CPE, which is the Compliance Program Effectiveness, I will be using that acronym often, we received over 150 comments from different organizations, sponsors, advocacy groups, trade organizations, pretty much anyone who had an interest or an investment in the Medicare program. And some of the major themes of the comments focused on tracer evaluation, improvements to the audit elements, the record layouts, the on-site interview process when we're on-site with compliance professionals, as well as how we resolve compliance issues while on-site as well as after the audit's conducted. So just a plethora of changes to consider. And so I honestly believe that we've taken all of that information to make a protocol that will hopefully accomplish our goal of easing the burden on organizations as well as on others. So the objective of the CMS Compliance Program Effectiveness Audit is to evaluate a sponsor's performance with adopting and implementing an effective compliance program to prevent, correct Medicare Part C or D program noncompliance and fraud, waste, and abuse in a timely and a well-documented manner. So those are two important factors that are highlighted throughout the protocol. And so the review period, which has stayed the same since for the last 7 years, is 1 year. So 12 months preceding and including the date of the audit engagement letter. So for example, if a sponsor received its engagement letter on May 1st, 2017, the audit review period would be May 1st, 2016 to May 1st, 2017. And so that's a question that we actually received recently as what protocols do I use if I want to just do a mock audit or such? is it 2017 or 2016 since the review? It may be in your best benefit for CMS to select 3 internal auditing tracers versus 2. And then something else is new. Another, just to check in with the sponsor, we have a follow-up call about the tracer samples. So once we submit the tracer samples to you, we have a call we upload them to HPMS, and then we'll schedule a call immediately with the compliance officer, and you can determine who you would like to have on the call to go over the sample requests. So you know exactly what samples we've chosen, where we've selected them from, what universe, and any questions you have about the tracer summaries, how you would like to present those. It's just, again, a Q&A session, just to ensure that, you know, we're both on the same page. And we have something else new for 2017. So in previous years, we've selected a number between 5 and 20 employees' records that we evaluate to test for compliance with submission of that the organization has provided the code of conduct, certain policies and procedures as it relates to compliance, as well as OIG and GSA exclusion checks. For 2017, we are conducting this specific test on site. So on the first day, unlike the other samples, you will be provided 20 employees as well as board member names, and you will be expected to provide the OIG exclusions checks or evidence that you've performed those checks, as well as evidence that receipt of code of conduct and any other requirements that are outlined in Chapter 9 and 21, the compliance program guidelines. So during the sample follow-up call, if there's any issues with you have an external vendor for your OIG GSA and you may need some additional time, that is definitely some of, that's where that discussion needs to take place, so that we're aware of how we may need to maneuver to make sure that, you know, both parties are in agreement with how we will proceed. So we're going to select 20 employees and board members, so it's a combination, but only 20 records. So for the on-site, so after week 1, or the program activities for CDAG, ODAG, SNP-MOC, and or formulary administration, the small CPE team arrives on site at your organization. And so we have restructured in a way, we've streamlined week 2, which is referred to as a CPE on-site audit, and then we hopefully it's more transparent, as well as it allows organizations to decide what resources are needed where. So for day 1, we have a walkthrough. After the welcome, we set up that good stuff. We have a walkthrough of your compliance program. So that's really, in prior years, where we cover the 7 elements. This is where you go over, we will go over your presentation of the organization, your structure, who's who, your risk assessment, any questions that we have about the documentation we reviewed prior to arriving on site. That is where we will discuss those issues. Also on day 1, we will complete all of the compliance interviews. So those are 3. We have an hour interview with the leader of the SIU division, or if you don't have a SIU, the function that performs those fraud, waste, and abuse prevention, detection, and correction processes, as well as we have an hour interview scheduled with the compliance officer, and an hour interview with the party or parties that manage the delegation oversight within the organization for Medicare operations. So that's a full day. And then we usually have a wrap-up after each day, just for 15 minutes with the compliance officer to go over the document request list and just preview what will be covered for the next day. Day 2 is focused all on tracer samples. A tracer sample can range from 1 to 3 hours. It really depends heavily on how detailed the tracer summary is. And again, if you have any questions about, okay, well, how do I organize my thoughts? Because I can see now that we don't provide a template, how challenging that can be. Please reach out to your audit lead or your CPE audit lead once you have that, that person has been designated to get some insight on how you could proceed with that. Because they could, if it's detailed, we can get through that tracer. And on day 2, we would like to, if possible, between days 2 and 3, review those employee records to ensure compliance with the exclusion checks. And so one of the questions that we received often recently is like, how many months should I be prepared to provide for the ECT review? And it's the 12 months. So that can be, just keep that in mind, that it's the audit period that you have to provide. I'm going to jump around. I know I have my other colleagues. A huge significant change that we've had is the audit elements. So traditionally it's the 7 elements that are listed to the left. And now we are focused on the 3 actions, the 3 core actions of a compliance program. And this is to show with the question that I received during the pre-area process is, okay, so where did these 3 core functions come from? Well, this is what a compliance program is supposed to do, or what is designed to do. And you will see in a protocol how we correlate that to the 7 elements. I mean, it's all embedded within each other, and the tracers, the way that they're designed to tell the story in chronological order, the core elements of a compliance program will play out. So we're confident in that. So for prevention, this particular element evaluates the sponsor's internal controls to reduce the number of potential non-compliance and fraud, waste, and abuse, and regulatory violations from occurring within all Medicare business operational areas by employees and delegated entities. These compliance controls provided the framework for which the company and its employees operate, convey compliance expectations, prevent repeated issues from recurring, and deter minor issues from becoming significant problems with adverse impact to the sponsor's operation and Medicare beneficiaries. So you will see here, these are what we consider preventative controls that we will evaluate during the audit, the CPE audit. And again, if you want to think of it in the core element perspective of a compliance program, you will see that's element 1, 2, and 3. Now, I do want to note that compliance, the elements or the compliance standards, that preventative measures could be detection, depending on how the tracer, the issue is handled. So we do take that in consideration during the audit. And just one quick thing about detection that I want to highlight is while this is a second audit element, this element tests the effectiveness of the sponsor's internal controls that should have detected the issue of noncompliance. So you will, the auditors will continually ask you that question, is during the tracers, is okay, that you became aware of this issue for detection, and so why did you pursue this way, and what guarantees you or provides assurances, that's a better word, that that you were able to identify it within a timely manner. And timely, again, is based on your operating procedures. So that's for that. And for correction, correction is pretty straightforward. This audit element evaluates the sponsor's escalation process. So again, we will be asking, that is critical for us to understand, because we understand that not all issues go to a board. Not all issues go to the compliance officer. You may have within your organization, a compliance officer for business areas versus, just a Medicare compliance officer. So our job is to understand your business processes and then to follow and to ensure that those that issues are processed in the way that you have structured within compliance of CMS requirements. So I hope that makes sense, but it's really our job is to understand your business. So while the third element is correction, it's really focused on testing the effectiveness of your responsiveness. So we're looking at timelines here, your approach to the issue of noncompliance or fraud, waste, and abuse. And so the question here is, was there an appropriate plan of action for correction? And I understand that appropriate is subjective, but that is why we test, while it's a small number of tracers, it is a very comprehensive. So the tracers typically can be a appeals and grievance audit, a monitoring of your SNP process, an audit, I'm just thinking of some tracers, an audit of your PBM specifically for data that they submitted on your behalf to CMS that was incorrect. So asking that question, was there an appropriate plan of action for correction? It depends on the situation. And so that is your job to tell us. Okay, and I'm almost done. This is record layouts. I'm not going to read this to you. So it covers, this is for your information and for those that are joining us on the webcast. It's just some clarification for each record layout that we've received recently that we would like to, provide that information to you. So again, I'm going to forward over in essence of time. So if you have any questions, you can definitely, any audit-related questions to the audit mailbox. CPE, specifically policy, for regulations or the compliance program guidelines, please submit it to the box. Myself, as well as my colleague, we monitor that and answer those questions as immediately as we can. And here's a website for where all of the audit information is available to you. So I will turn this over to Marla and Lauren.
Thank you very much, Vernisha. So we're going to change gears a little bit and focus in now on the Medicare and Medicaid plans and how they fit into the overall CM program audits. So I'll be honest, not knowing the audience out there, we want to provide a little bit of background on the Financial Alignment Initiative and how Medicare and Medicaid plans came to be. Then we'll talk about how they fit into the 2016 program audits last year and now what we're doing for the program audits in 2017. So just by, again, way of background on the Financial Alignment Initiative and Medicare and Medicaid plans in general, back in 2011, CMS announced new models that would work to integrate the service delivery and financing of both Medicare and Medicaid through federal-state partnerships. We wanted to create access to quality while providing integrated services to these beneficiaries. So through that, we've created two major initiatives. One is a nursing facility initiative that I don't have on these slides, but I welcome you to go to our MMCO website and learn more about. And then we have our Financial Alignment Initiative, which hopefully will be known to more of you. And under the Financial Alignment Initiative, we have three models. We have a fee-for-service model, which is when CMS is entering into an agreement with the states, under which the states are eligible to benefit from savings resulting from initiatives they take that reduce costs in both Medicaid and Medicare. We have our capitated Financial Alignment Initiative, which is our big one that you all may be familiar with, which is where we enter into three-way contracts with states and health plans to provide comprehensive, coordinated care and integrated benefit of both Medicare and Medicaid through managed care. And then we have a third alternative model that's actually leveraging the Medicare Advantage dual special needs plans to do some administrative alignments that we can do through an MOU. So my next slide just gives you a picture of the map of where we have the different models in play right now. So the fee-for-service demonstrations are happening in Washington and Colorado. Our administrative alternative demonstration is happening in Minnesota with the DSNPs there. And then we have 10 states participating in the capitated demonstration. I can tell you New York, though, has 2 different demonstrations. So we have 11 demonstrations in 10 states happening right now. So once these capitated demonstrations really became operational, CMS wanted to make sure that we were capturing their performance in the overall Medicare program audits. And we wanted to make sure the MMP lines of business were being looked at. So to that end, we began including the MMPs in the parent organization audits last year. Overall, CMS did a lot of audits last year. There were 37 parent orgs that covered 168 contracts. And if you break that down, there were 8 parent organizations that operated 19 Medicare Medicaid plans across 7 of our demonstrations that were captured in the program audits last year. Let me just say, for everyone's peace of mind, the MMP-specific findings that happened last year were documented in the final audit reports as observations. They were not counted in the overall parent org audit score in their audit reports. That's not to say that some of the observations did not include corrective actions for our MMP-specific findings, but they were really just observations in the final report and weren't counted towards that overall score. But what we saw very quickly as the audits were progressing throughout the year is because the MMPs were operating under 3-way contracts, there were differences between Medicare Advantage and the requirements outlined for the plans in the 3-way contracts. Some of the biggest areas were in appeals and grievances, or timelines to complete health risk assessments, the membership of your ICT, the care teams, and some of the covered services. Like one of the biggest differences between Medicare Advantage and our MMPs is the covered services include long-term supports and services. So it's just looking at a different scope of services than in a Medicare Advantage audit. And it became, at least on the audit I attended, I would say the proverbial square peg, round hole, trying to make the MMP line of business fit into the Medicare Advantage protocol. And so for 2017, we wanted to do better than that square peg, round hole. So that is why we worked to develop some MMP protocols this year. And we released them for comment back in February, and we got a lot of comments. MMPs, DSNPs, industry, advocates, we heard from everybody. And we recently released the final protocols on April 28th. So fairly new, and not sure everyone's gotten them yet, but they're out there. They are called the MMP Service Authorization Requests, Appeals, and Grievances, or SARAG protocol, and the MMP Care Coordination and Quality Improvement Program Effectiveness Protocol. I'm not going to say the acronym. There's debate internally at CMS of how you pronounce that, so I'm just staying clear of it. So I just want to do some major highlights of the feedback we got from all of you and your comments and how we changed the draft protocols to what we released in April, and Lauren will get into some more of the technical aspects for us. But first and foremost, these will be pilot protocols for the 2017 contract year. So any parent organizations that have MMPs that get audited this year, these 2 protocols will be pilot. And we really tried as much as possible to leverage the existing Medicare Advantage ODAG and SNP mock protocols where we could. We tried to keep terminology the same, even if we had originally done it differently in the draft. We're trying to really standardize them as much as we could, respecting the fact that the 3-way contracts sometimes have much more specificity, and we're really trying to audit the organization against the requirements in the 3-way contract. So you will see at the beginning of each of these 2 protocols is a definitions section. I would say that's very much for the ease of reading the protocol that we've included those in the protocols, but you should always refer back to how terms are defined in your 3-way contract. That would be what the auditors are going to be looking at when they audit. We also took your feedback about the amount of data elements we were collecting for the universes, and we've certainly scaled that back significantly, especially in terms of claims and call logs. I think you'll see a great difference from the draft protocol to now the final pilot protocols. But most importantly, I also want to clarify how the pilot protocols will work into scoring, which is to say they will not be part of your parent org overall audit score in 2017, just like 2016. Except this year, they won't be considered observations if there are MMP-specific findings. There would be CARs, things like that. If there's corrective action, we are looking for validation for the audits. But these pilot protocols will not count towards the parent org scores, so it will not impact star ratings for our parent organization. Just want to emphasize that for everybody's peace of mind. But want you to know that we are going to be including them in the final report. They won't be in the executive summary, any MMP-specific findings, but they'll be in the actual body of the report. So with that, I'm going to turn it over to Lauren to speak to you in more detail about Universe's data elements and the technical aspects of the 2 pilot protocols. Thank you. Oh, sorry.
Thank you, Marla. Okay, so let's discuss the MMP audit process, including what changes sponsors with MMP and MA products can expect. MMPs can expect to receive notice that they've been selected for audit 6 weeks prior to the fieldwork via the engagement letter. For sponsors with MA and MMP products, your program audit engagement letter will also include information about the MMP review. As Angelique mentioned in the previous session, the program audit will be extended by 1 week for a total of 3 weeks. The SARAG and KIPI reviews will take place during week 2 of the audit, and program or compliance program effectiveness, or CPE, will take place during week 3. Both the SARAG and KIPI reviews will be conducted over webinar with no on-site presence. Sponsors with both MA and MMP products would submit all program audit universes, including ODAG, in addition to SARAG and KIPI universes. The sponsor would populate ODAG universes with MA cases only and populate SARAG universes with MMP cases only. No other program areas will be impacted by the addition of the SARAG and KIPI audit protocols. Further instructions regarding universe submissions would be provided during the follow-up call after receipt of the engagement letter. Lastly, for sponsors with both MA and MMP products, MMP contracts may be cited in the final audit report in program areas other than SARAG and KIPI if MMP members were affected by an issue of noncompliance identified in other program areas. For example, it is possible that an MMP contract might be cited in an ODAG clinical decision-making related impact analysis if there is overlap in the sponsor's MMP and MA clinical decision-making process. Now I'm going to discuss the new MMP audit protocols individually. We'll start with SARAG. SARAG tests 3 elements: timeliness, appropriateness of clinical decision-making, and grievances and misclassifications. So for timeliness, although MMP timeliness requirements can be consistent with MA processing timeframes, for example, Part D coverage determinations and appeals, they frequently diverge from MA requirements, which is why MMP timeliness will be evaluated separately from the MA contracts for medical requests. Timeliness related to claims payment requests from providers and state fair hearings overturns will not be evaluated. In regard to the second element, appropriateness of clinical decision-making and compliance with SARA processing requirements, for sponsors that have previously undergone an ODAG review, note that the SARAG review includes new MMP-specific requirements, such as aid pending appeal, and the appropriateness of clinical decision-making and notification for cases the State Fair Hearing Office overturns. Additionally, the appropriateness of the clinical decision-making element will include the review of service authorization requests and appeals for behavioral health, substance use, and long-term services and supports, or LTSS. CMS will sample 40 cases for this element, regardless of the number of MMP contracts reviewed for one sponsor. We will evaluate each case selected based on the applicable contract-specific requirements. For grievances and misclassification of requests, the documentation universes and compliance standards are almost identical to ODAG. There is one difference in the standard grievance record layout in which CMS asks MMPs to identify whether the grievance involves behavioral health, substance use, or LTSS services. So the SERAG review includes 12 universes. As Marla mentioned, there is a significant amount of overlap between SERAG and ODAG record layouts. Note that there are no SERAG universes equivalent to the ODAG universes for direct member reimbursements, payment reconsideration requests, or dismissals. Additionally, since New York MMP's external appeals are subject to review by the Integrated Administrative Hearing Office, or IAHO, not the Independent Review Entity, or IRE, IAHO cases will be part of the State Fair Hearings Decisions universe, and New York MMPs would not submit data for the other IRE-related universes. The SERAG universes have some new data fields. For example, the field issue description and type of service has been separated into 2 data columns for the new record layouts. This was done for sampling purposes. Fields pertaining to aid pending appeal have been added as well, and you'll notice a few fields that are relevant to MMPs contracting with a particular state, but these are minimal. Some response options for familiar fields have been altered. For example, in acknowledgement of the role of the service coordinator and what they do in terms of submitting service authorization requests on behalf of members, we are asking MMPs to identify whether a request was submitted by the service coordinator if that information is tracked by the MMP. So for the call log record layout, that has been altered to identify optional data fields. This is in line with the ODAG and CDAG call log record layout, and were changed to reduce MMP burden. As stated in the protocol, MMPs can submit this data in their preferred format as long as it includes the minimum data that CMS is requesting. So some of the comments that we received on the draft protocols related to SERAG touched upon these themes. Commenters wanted to know if Part B point of sale drugs should be included in the universes and whether to include Part D drugs. As stated in the universe preparation and submission section of the protocol, SERAG universes should include prescription drugs that would be processed under Medicare Part B, but would exclude all other prescription drugs. Therefore, sponsors would not include Medicaid-only prescription drugs or Part D drugs in the SERAG universes. This would include the exclusion of grievances and calls related to Part D drugs. Also, in response to commenters, CMS will permit MMPs to exclude concurrent review for inpatient hospital and skilled nursing facility services, post-service reviews, notifications of admission from the universes. If the MMP has already programmed its system to include these requests in its universes, we will accept the universe submission. Note that requests for extensions of previously approved services have not been excluded, although they can be excluded from the ODAG universes. So I just want to point out that difference. Okay, so now let's talk about KIPI. As Marla noted, the KIPI protocol closely resembles the SNP mock protocol. One of the major differences between the protocols is that CMS will evaluate MMPs against the specific requirements for the three-way contract rather than the mock, the model of care. However, CMS has asked MMPs to submit their model of care at the time of their universe submissions. Also, in contrast to the SNP mock protocol, the KIPI protocol does not have an enrollment verification element. Care coordination will address the timeliness and administration of the health risk assessment, the individual care plan, appropriateness and implementation, and the interdisciplinary care team composition, qualifications, and functioning. We'll also look at the coordination of member transition across care settings. Unlike CERAG, the KIPI review would include Part D drugs. Part D drug claims should be accounted for in the Medicare and Medicaid plan members universe, and CMS may review care and case management documents such as prescription drug events that would include these claims. Quality Improvement Program Effectiveness will review the performance of the MMP's quality improvement projects to determine whether the MMP has collected data on performance measures, analyzed the results, and has taken appropriate action when a performance goal was not met. For both care coordination and quality improvement program effectiveness, CMS will evaluate how the plan has integrated member and or member representative participation. The Medicare-Medicaid plan members record layout is the universe from which CMS will select 30 members for the care coordination review. All of the sponsors' MMP contracts will be represented in the review. In response to commenters, CMS has removed fields in the Medicare-Medicaid plan members record layout that required breakouts of approved and denied claims, payment numbers, and amounts for behavioral health, substance use, and LTSS services. These fields were removed to reduce MMP burden. And now only requests for cumulative totals remain. Additionally, due to the nuances of the setting or method by which the health risk assessment could be conducted, CMS removed the field requesting this data, and we will look at it on a case-by-case basis during the actual review. Okay, so if you have any questions about the audit process or MMP contract requirements, you can email the audit mailbox or the coordination office at the following email addresses, and this concludes our presentation.
Awesome. Thank you. Okay, if you have questions, would you please hold them until the afternoon session when we do the Q&A session, as we are out of time right now. But I would like to thank Vernisha, Lauren, and Marla for sharing the information on program audits. We will be evaluating this session, so if you'd like to evaluate this session, go ahead and select A, follow the link, and answer the questions. We will be taking a 60-minute lunch break, and we'll begin this session, or the afternoon session, promptly at 12:30. For our in-person guests, there is a cafeteria downstairs, and for those who pre-ordered your lunch, you can pick that up at the Jazzman Cafe. Thank you very much. Enjoy your lunch.